All right. Well, hi, everyone. This is Naveen Kella, Dr. Kella. I'm a urologist here in San Antonio, have a fellowship in urologic oncology, and we treat general urology as well. And I'm really excited to have Dr. Rao here, who's a board certified interventional radiologist. We met because of her interest in what is called PAE, prostate artery embolization. And prostate artery embolization, I've known about and heard about, but it recently became part of the AUA guidelines, the American Urology Association guidelines, as a treatment for BPH for patients who are failing medications or who are averse or not candidates for surgery. So, Dr. Rao, why don't you tell me a little bit about yourself and how you became an interventional radiologist and your interest in PAE?
Sure. First off, thanks for having me on. It's always great to share information with other people who are on the same page in bringing new advanced treatments to patients. And so my name is Dr. Rao. I'm a vascular interventional radiologist by fellowship training. I initially actually started off in my surgical career. I did surgery residency. Initially, I thought I'd be going down the path of doing open surgeries. But what I realized was I really was interested in providing the most minimally invasive type of treatments to patients. And that's where I sort of diverted my path and went down the path of doing image guided treatments, where I do all these treatments, oftentimes just using the size of a pinhole, using a needle, using an IV basically, treating a wide variety of conditions that oftentimes surgeons deal with from a different standpoint. So our shared interest here is, of course, is the fact in the area of urological treatments, but we'll certainly get into this, I'm sure, over the course of this little discussion. But when it comes to men's health, there's a lot of newer treatments that I feel that from a vascular interventional standpoint, we can go in and I could try to access and direct the treatment by going in specifically through blood vessels. And I can see that using image guidance. I can see it using X-ray or fluoroscopy. And so that's really where I come in and where I'm able to help you guys out.
Right. I know we've talked about this a little bit offline, how interventional radiology is more than just prostate artery embolization. So that's, to me, really exciting because there are some problems definitely that could be done less invasively, or perhaps we can't even really address well as urologists. As far as PAE goes, can you tell us a little bit about how long you've been practicing now and just how many procedures you think you've done at this point in the vascular space?
Sure. So I finished my fellowship training in 2011. I finished at Johns Hopkins. I did my vascular interventional radiology fellowship there. At the time, prostate artery embolization wasn't really, it was just sort of being initially coming up. It was a lot of these treatments that we have for men's health were just being discussed. A lot of them were being evaluated overseas. And so I actually jumped into the area of prostate artery specifically within, I would say, a year after finishing my training. So in about 2012, I started doing my first prostate artery embolizations when I was in practice. So it's 2026. So, I mean, almost 14 years I've been doing prostate artery embolization. So, I mean, when you ask me how many, I don't have the laughs there, but I can tell you when I first did one, I still remember when I did in 2012, the local newspaper showed up because it was a very new thing. I remember being featured in the news on the US side. And I even started getting patients from Mexico because I live out here very close to the Mexican border. So there was a lot of interest with it because it was a very brand new procedure at the time. And now obviously it's gained a lot of traction throughout the community, not just IRs, but also urologists. Everyone seems to understand it. So I would say just over this years, I mean, there's definitely thousands, but I would say when I first started doing it, I was definitely one of the first people to do it, especially when I did it. One of the first ones in the Texas, New Mexico area. Now I'm very happy to bring the procedure to your patients in Central Texas as well.
So, I mean, where is this procedure performed? I mean, I know a lot of patients probably have no idea. I think they might think that it has to be done in the hospital setting. Can you tell us a little bit about where it's performed and what is the process for a patient when they get PAE?
Sure. So Back when I first started out 12, 13 years ago, started doing this procedure, we started doing them in the hospital. But as I've gained this over a decade of experience, I've realized you can do this very safely, efficiently in the outpatient setting. I can do it in a clinic, in an office, outside the hospital. And we all saw what happened during COVID, people trying to not be exposed to a lot of the pathogens, all the stuff that you get in the hospital setting. So that really pushed this even further to having it done very safely, effectively, efficiently in the clinic space. So currently we're doing it out of a clinic that we have. We have the top of the line imaging capability that I have in any other hospital-based facility. We have the X-ray guidance, fluoroscopy guidance to be able to do it. We have the same tools, the same catheters, the same medications, the same particles that I would use that would do it in a hospital setting. We can do it in safely and effectively. And the nice thing is, it's a much more easier process for patients to navigate. When you come to an office, you're just walking a few steps, coming into our clinic, being seen, being treated quite immediately, and you get to go home within 30, 40 minutes after the procedure. There's no significant downtime. So it's all designed to make the patient experience much more palatable.
Mm-hmm. I guess as we go into the procedure, a lot of patients will probably immediately want to know, is this a covered procedure by insurance? Is it a FDA approved? Yeah, it is part of the American Urology guidelines now, but what would you tell patients if they have questions like that?
For sure. So this has been a long path to getting widespread approval. So when we first started off, yes, it was very brand new at the time. Maybe some people might say it was more on the experimental one, but that's looking at over a decade ago. But now it's great that even the main societies, the American Urological Association, they're all also jumping aboard with this procedure. So it's not just some things that when we were doing initially, there's like a few mavericks here and there. They were trying to figure this procedure out. Now it's gained widespread approval from the FDA. Most major insurers cover this, pay for this. So you aren't having to dip into your pocket to get this procedure done. But there is definitely some hurdles when it comes to approval. So that's where our clinic team will, when you come in, make sure that your insurance covers it. Because the last thing we want to do is bring you in for a procedure and you have some unexpected hidden fees or costs. So we definitely vet that whole thing out. Make sure when you come in, we know we're offering you a procedure that we can actually treat and it will be covered by your insurance.
Yeah, I think PAE, when I see patients in the office and they're having problems with their urination and it's due to their prostate, most of the procedures we offer are covered by insurance, but there's certainly anytime there's something new, and like you said, PAE is not new, but anytime there's a therapy that is growing where initially it wasn't being done too much, a lot of times insurance can be a problem. But I'm really happy. I know it's covered by Medicare and most of the other insurances are following suit. And I guess that brings into, usually the patient will come in and see a urologist first. And we're talking about different options. Usually we'll talk about medications. If they're not already taking medications, drugs like Flomax or Cialis for daily use, eventually those medications for most patients stop working over time, or there could be side effects. And then we get into procedures. And it used to be just one procedure we had. We used to just have the TURP, which is still a procedure that we do. It's very effective, but there's certainly risks. And also there's bleeding involved. It has to be done in the hospital. So not everyone is interested in doing it. And not everyone is actually a candidate for it. And now we also have a lot of other minimally invasive procedures we do. But to me, PAE has a lot of advantages that some of these other therapies don't. Like first thing patient asks me when I have a patient in here, I tell them, well, after we're done, you're going to have a catheter when you wake up. You're going to be in a hospital potentially recovering. You may even have to stay overnight. There's going to be some bleeding depending on how we do the procedure. I guess, can you tell everyone, like, how is PAE done and how it has some of these advantages that some of the procedures that I offer may not have?
Sure. So I think one of the nice things about the prostate artery embolization procedure, when you have it done with me or with us, is that I tend to do the vast majority of them, like 90% of these, just for a little IV in the wrist. You might be wondering, how do I get from the wrist down to your prostate? So basically, I get in through the wrist into the radial artery. I first check out your radial pulse to make sure that you got a good pulse. I go down with a little wire. I'm not entering the heart. I'm going around the heart to the blood vessel going down the aorta. And there's two blood vessels going into the iliac arteries, and then eventually I'll work my way down to the prostatic artery branches. But I get into the exact blood vessels that are feeding the prostate gland. And so I see all this and I know where I'm going with image guidance. So when you're getting a procedure done, you're flat on a table, face up. I'm working through your wrist, so you feel maybe a little bit of numbing medication when I initially put it in, but we'll give you sedation if you want it. I actually have some patients who actually tell me they don't even want sedation. They want to be able to go home even faster. I've had some patients say, I don't want sedation because I want to be able to drive myself home. I've had that for some patients who actually come in from far distances. I've had patients who've even come in to get the procedure done with me, then they want to go home on a flight the same day. So they want to get in and get out pretty quickly. But I see all these blood vessels, this pathway to your prostate using X-ray, using image guidance. And so once I know I'm in the right spot, once I confirm that with X-ray, I put the bead particles in. So there's a lot of different particles out there, but these little particles are about the size of a smaller than a grain of sand, really. And these beads are designed to block the flow. So I use these same particles for a variety of different organs out there when I'm treating different organs, but in this case, I'm obviously treating your prostate. So the goal is to put as many of this sand-like particles and block off as much of the flow to the prostate gland. Now, there will still be some flow going to the prostate gland because it's difficult to capture every single thing. My goal is to deprive the prostate gland of the vast majority of blood flow. So what that does is, by depriving the flow, it should hopefully start shrinking to a more normal size. Hopefully it'll start softening up. There might be some of the prostate cells that have overgrown, maybe they may die off, and then this prostate gland softens up a little bit, that thereby putting less pressure on your urethra, the little tunnel where your urine comes out from, your pee comes out. So really that's what I'm doing. I'm trying to get into the prostate, shut down the flow, so that your prostate goes to a more normal size. Now, there are folks wondering, how does this work? And besides just shrinking, causing cell death there for the prostate gland, now there's also thoughts that the testosterone that you have in your body is not going to be able to impact your prostate cells as much. So going forward, hopefully you won't have further growth of your prostate gland. Because remember, if you live long enough, I think your prostate will probably get bigger. And that's the reason for that. The fact that we have all these hormones in our body, testosterone impacting our prostate gland, is going to force it to get bigger. So by putting this material in and impacting the prostate cells, I'm able to, one, immediately within about hopefully 3 to 4 weeks. Sometimes I've seen it as quick results as quick as 1 or 2 weeks. Start seeing your prostate soften up, shrink to improve your urine flow. And second, hopefully keep it reduced in size for ideally at least five years or so if we can, 5+ years if we can.
How long does it usually, for a regular patient, a regular case, how long does it take you to do one of these cases?
Yeah, so if you told me the most routine case, which is straightforward, you got a really big, nice prostate, nice big vessels going in there, I can usually try to finish it. My goal is to do it within an hour. Obviously, there are some patients who have weird anatomy. Sometimes maybe I can't reach from your wrist. Maybe you're too tall. Maybe you have some what we call tortuous vessels that are very squiggly, serpentine. So it's difficult to get in there, but in which case I might have to use a secondary access. That might add on time, but most of the time I can finish up the treatment within an hour and a half or so. That's my goal. And so you come in, and then after the procedure, I'm just putting a little rubber band, sort of a wristwatch type device, to put pressure on the little IV site that we went in. And hopefully after 30 minutes or so, you can go home.
Oh, so if someone's too tall, what is the alternative? You go through the groin, I assume, but it sounds like there's less risk the way you do it typically going through the wrist. But should someone be concerned if you have to go through the groin?
No, I can do both wrist or groin. I personally like the wrist for 2 reasons. One, I think it makes the procedure a lot more comfortable for you as the patient. You don't even have to really even take your close up. I'm literally it's like any other IV you put in, except instead of going into a vein, I'm putting it into an artery. And so it makes the procedure feel a lot more comfortable. You don't have to lay flat after the procedure for a certain amount of time to recover. Those are sort of the main benefits. From a procedural standpoint, I personally think it's a nice straight shot into the prostate gland, coming down straight into it, as opposed to going from the groin, making a 90-degree turn. But when most recently I did a few prostate cases, one of them I went to the groin. That's how we initially sort of started doing these. Going from the groin, no big problem for it. I get the very similar sort of success rates going from the groin or going from the wrist. It's mostly, honestly, patient preference and making it a lot more comfortable for the patient to be in and out without much soreness after the procedure.
And when you say a typical case could take an hour or less, obviously you said sometimes they could take more. Patients will ask, and I was wondering too, as far as radiation exposure, is that something you can talk about a little bit?
Sure. So what I would say is there's radiation exposure with everything you do, whether it's taking up flights. If you decided to catch a flight, there's radiation involved with catching a flight. There's radiation with the routine x-rays you have done. Now, there is radiation involved when we do this procedure, simply because it's a series of x-rays I'm taking with fluoroscopy to look at your prostate gland. So there is a risk with radiation, but most of the risks associated with radiation tend to be when you are younger. So if you said you're being exposed to radiation when you're, let's just say in your teens or when you're younger, that radiation that you get hit with has a lot more time to affect damage on your DNA, on your cells, over a much longer period of time. Now, most of the prostate patients we come in, you're typically an older gentleman, anywhere 50, 60, 70. I've done 80-year-olds. Even if you did, let's just say worst case scenario, you do get hit with some radiation that causes some damage to your DNA. The amount of time it's going to take to actually cause a actual cancer or any other sort of significant change on your body is actually very, very minimal. So really, it's a risk benefit thing. And when it comes to any procedure, especially in the radiology space, there's always risks associated with radiation. But to me, the fact that you're looking at older patients and the fact that there's some radiation involved, the amount of benefit that you get really overwhelms the amount of risk that is from radiation.
And we've kind of mentioned some of the big advantages of PAE, but for other risks, side effects that could happen, I've counseled patients in the past about, well, the radiologist has to put the really tiny beads into the prostate. There's a chance that they may not make it to the prostate, so you may not get that effect, or they could potentially put the beads in another artery close by the prostate. So you could have issues to the penis or to the rectum, for example. Now, I've read that these are usually oftentimes very transient and can heal up, but what's your take? What's your take on that? How do you counsel patients about those types of risks?
Absolutely. In a perfect world, every single one of these thousands of beads that I would put into your prostate, every single one would go right into your prostate gland and they would all be perfectly delivered. But we all know that's very difficult because you're injecting a lot of these little particles. There's lots of abnormal connections. So here's kind of an example. I'm not sure how well you can see it, but we see the prostate artery arising off a blood vessel that's close to the urinary bladder. Okay. So it's not difficult to think that some of these little particles could go into your urinary bladder. Now, there's such a good collateral path of all of this other good blood vessels that go to your bladder that the chance of having significant damage, significant long-term damage to your bladder is very, very minimal. Now, what will you expect if a particle goes invariably into your bladder? Well, you might have a little bit of burning sensation. You might have a little bit of spasms, and we give you medications to counteract that. And so hopefully a lot of these side effects that you might have, maybe it lasts a couple of days, maybe it's for a week, where you have a little bit more bladder irritation. It's not going to be something that you're going to live with long-term. Now, I've had some of these particles also. There's a vessel that sometimes goes near the rectum. I've had a couple of these particles go and irritate the rectal artery. So you might feel like rectal spasm and not actually having to go to the bathroom. I've had some of those patients, again, a self-limiting condition, which hopefully lasts at most maybe a couple of days to a week or so.
Okay.
Now, the one question guys often ask me is, what is the chance that I'm going to have significant problems with erections, erectile dysfunction? What if it goes down into the penile artery? Now, the chance of having actual erectile dysfunction, that's very, very difficult to see. I've not seen any of those complications with it. Now, what I have seen, however, because invariably, sometimes the prostate artery does come off the what we call the pudendal artery, or the main blood vessel going down to the penis, the penile artery, right? So when it does happen, most of the time it is self-limited, but a worst case scenario, and if this has happened to me, I would say maybe one in about 500, one in 300, 400, 500 cases. It's very, very rare. But sometimes they might develop a little blister, which will be painful. If it happens, the patient won't like me for it, but it's a blister that will heal up. It's going to be, it'll look like a little ulcer maybe, but like anything, because of the fact that there's so much good blood vessels, collateral blood that goes to your penis, that ulcer will heal up. So basically what I do in that situation, I give you some creams. There's some lidocaine creams, Silvadene creams to help take care of the pain. But when I've seen this happen, usually within about, I would say it takes anywhere from 3 weeks to about at most maybe 8 weeks for there to be a turnover in the epithelium, in the skin cells of the penis to be able to heal that blister. So again, it's not something that you're going to be like having as a long-term problem, side effect, or complication. So the nice
So,
thing is it's all short-term sort of side effects, which we can usually manage with medication.
so I think I've read, and this is probably from old literature, but like penile sloughing, you mentioned this ulceration that can be painful that resolves because you have such good blood flow around the penis. But someone losing their penis, I would imagine that would be extremely rare, like almost unheard of nowadays.
Oh, absolutely. I mean,
Okay.
especially in our hands. I mean, I have image guidance. I can see exactly where these particles are going. So these particles that I put in, I mix it with contrast, which is basically a dye. And so as I'm puffing it into your blood vessel, I can see the dye go in. And that means as I see it, it basically lights up. I can see each particle as it goes in. So I am delivering it directly into your prostate. Every now and then you'll see maybe a little particle. Sure, it could go into your penile artery, your bladder, your rectum. But at that point, once we know it's too much, we stop. And so, or there's ways to avoid having it go down that pathway. So there's lots of different things that we can do to really minimize the chance of having any sort of complication.
Okay. And you mentioned that maybe for a week or two, or for a week, you could have symptoms, but how, if you have a patient who, sometimes you have patients without a catheter, and that's who have a catheter because they can't urinate at all due to their prostate. Their bladder is still working or is damaged, but it still works enough where if their prostate was fixed, they could urinate. And that happens to be in one of the indications for doing a PAE, right? How long would you tell a patient to wait before they should expect to start urinating a lot better?
Absolutely. In fact, one of the patients you sent me a while back was a patient who was initially catheter dependent. He had gone in, I guess, initially to either your office or the emergency room, could not pee. They put a catheter in and he'd been living with it for at least a couple of months. And he was very anxious. He's been wanting to get that catheter out. So he's like,
Right.
how quickly can I take this catheter out after your procedure? So I always tell people, wait at least a couple of weeks before you attempt a trial to remove your catheter. The reason is when I initially put these beads into your prostate, there's a period of time of about 1 to 2 weeks where your prostate is adjusting to this new flow. It might feel a little bit more inflamed. The symptoms will wax and wane. Maybe one day you'll feel great and just your urine wants to go out. Some days it might clamp down a little bit more. You don't want to remove your catheter during this period of time. You want to wait till it calms down a little bit, which I would say a minimum, wait a couple of weeks, and then we can do a sort of a trial. And so what I typically tell folks is when you do this trial to get your catheter out, take it out first thing in the morning and then drink your normal fluids. And then if you feel that you can get through the day without having an issue, then hopefully you're now free of a catheter. Avoid removing it in the middle of the night or like at the end of the day, because then
Right.
what happens if all of a sudden you wake up at 3 in the morning and you have to put it back in urgently because you are in a period where you're not able to remove it. Your prostate has not shrunk down, softened enough to have it removed safely. I think we can wait a couple of weeks at a minimum to do a voiding trial and hopefully get that catheter out, because that's my goal. My goal is, after every procedure, I have two goals. If you have a catheter, my goal is to remove that catheter as quickly as possible. The other goal is, if you're on any of these medications, if you're on tamsulosin, Flomax, if you're on finasteride, or some folks are taking Cialis, what have you, if you want to get off those drugs, again, I tell folks, wait a couple of weeks at least. I want to see how you do. And my goal is, if you want to get off those drugs, I want to be able to get you off those medications as well.
Yeah, I mean, with all the procedures that we do, day one of urology training is do not remove the catheter in the evening time, because you don't want the patient to have to end up in the emergency room. So those are definitely wise words. And you're right, that patient who's doing great, by the way, he is able to void. Those are the cases that usually we would take them to the operating room and do a TURP, or even this procedure called aquablation. But he really just did not want to be in the hospital, and he didn't want to be, quote, cut on. And he was worried about his ejaculatory function, which we have steps now that we can preserve ejaculatory function. But for PAE, I think it should definitely do a much better job with sparing ejaculatory function. Is that how you counsel patients?
Yeah, I think the main selling point is the preserved sexual function and the ejaculatory function. Now, I think you could probably address this even better than me, but the way I think about it is, a lot of these other procedures that the urology colleagues offer, your work, if you think about your prostatic, your urethra as like a tunnel, you guys are working from the bottom end and you're trying to open that tunnel up. The way I think is that your prostate, when you're having an orgasm, that ejaculate, the prostate's not able to squeeze down as much and push the ejaculate out. That's why you might have some folks who might have ejaculatory issues after a alternative, like a TURP or any other procedures. But with my procedure, my goal is, I'm going in through a blood vessel and I'm depriving the prostate of blood flow. So my goal is to overall globally shrink your prostate down. I'm not going to probably get it to totally normal size, but if I can reduce your prostate size by 30%, 40%, my goal is to hopefully help reduce that overall pressure on that tunnel. Therefore, your prostate can still compress and push the ejaculate out, and thereby you can still maintain a normal orgasm.
Right. Now, I think that's the way I describe it. As far as our surgical options, we're coring an apple. And when we core out the inside of the apple, sure, you have a much better flow because the bladder squeezes through the core. But now all those ducts and the mechanism for the sperm to go through the ducts or the ejaculatory fluid to go through the ducts is gone. So that's why a lot of patients after surgery they can still get orgasm, but nothing will come out. It's a dry orgasm. And we see that with medication too. Medications like tamsulosin or Flomax, which is its trade name, are notorious for doing this. For PAE, you said PAE, it can last for at least 5 years, or hopefully it lasts for 5 years. If that happens to a patient, what are their options at that point? I mean, can they do PAE again, or should I have some other therapies reserved for them?
I've actually had patients who they got the procedure done, got a great outcome, and they were, in some cases, they were catheter free for 5 years, and then all of a sudden they started noticing some return of their symptoms, like you described. All of a sudden they have to get up many times to urinate. They have a lot of frequency, urgency, all the classic symptoms. And they come back to me and say, can we do this again? And the answer is absolutely. Now, the reason is, over that time, it's quite possible those same blood vessels that I have blocked off, either you've created now over this 5-year window of time since our treatment, maybe your body has now created new pathways to feed the prostate. Just like if you're going down the highway and you shut down the main highway, now all of a sudden you have all these other pathways, all these side streets, people start going through them. Same thing. Maybe now there's other pathways that want to start feeding your prostate. So now I can go after those other pathways. The other thing I've seen is maybe even this big blood vessel, your prostate artery, I initially blocks it off, but now all of a sudden that whole artery just starts to get bigger because all of a sudden it wants to just open that existing vessel that's clogged up. And so now you'll have flow just around this plug that I've created in the process. So regardless, in either situation, I can go back in and I can retreat you, and hopefully you'll get an additional 5+ years, hopefully, of symptom-free relief.
And I think, from my perspective too, if let's say for whatever reason they're not a candidate for PAE or they don't want to repeat PAE for some reason, I've told patients that it doesn't burn your bridge to any other therapy. Sometimes when we do a procedure after, I've done one procedure for a patient who actually he had a bladder stone, I think, and he'd had PAE. And I actually noticed that I had to open up the prostate a little bit. So I think he had some regrowth, but when I was cutting away the prostate, there was hardly any bleeding as I was doing the procedure. So I thought that was actually nice because it made the case a lot faster and really a lot safer for the patient, because sometimes those cases can get bloody when we're trying to do multiple things during the surgery. Is there anything that they should be asking questions to their urologist or to the interventional radiologist so they can learn more about PAE? What would you counsel patients to be asking about?
I think if I were to be getting a PAE, or if I was telling my dad and he was considering getting a PAE and he didn't want to get it done by me, what would you ask your local urologist to get this procedure done? I think it's good to always know, like, what's your prostate size? Because I think one of the main things is we've seen definitely the prostate size reflects in terms of success of this procedure. So I've treated a wide variety of prostate size prostates that, even urologists are, sometimes scared of and want to shy away from treating because you may not get a great outcome. But I've also treated just barely bigger size prostate. So I think it's always good to know from the get-go what your prostate size is. I think that's always worthwhile knowing. I think most patients, it's going to be a straightforward case of just having BPH, having just enlarged prostate. But I think it's always worthwhile getting the urology input from knowing your PSA, things like that, to see, could there be something else going on? I think it's always worthwhile knowing that, because honestly, I'm not going to, every single patient who comes in, you don't want to just willy-nilly offer them a prostate artery embolization, because there's always going to be cases. That's what we're doing here, is we're identifying the proper patients who would benefit from this procedure. Was that being picked up? We can edit that out.
No, I didn't. Yeah, no, I didn't. I couldn't even hear it. No, I couldn't hear it.
Okay. It's my little computer was I think some game came on. Okay. But going back to that, I think, okay, so we'll start up here. So if you are going to your local urologist or your local IR doc, I think it's always worthwhile asking, how long have you done this procedure? How many of them have you done? Because I think that should give you more comfort in knowing if somebody's just kind of got into this space. I think it's going to make getting a complete procedure done a lot more difficult. So I think that's like the benefit of coming to us, is that I've done this for so long, over a decade of experience in this. I feel comfortable knowing that when I get in, I'm going to be putting the medication directly into your prostate gland.
What about patients who, as far as being a candidate, what if they're on blood thinners? We have a lot of patients who not only are on aspirin, but maybe they had a valve in their heart and they have to be on more potent blood thinners like Eliquis or Plavix. And those are always cases that I work with the cardiologist, but I'm anxious because after the procedure is done, we get them back on the blood thinners. And now with most of my procedures, we've cut the prostate, we've cored it. And so it's really prone to bleed. How do you counsel patients who are on these types of blood thinners?
I think that's where actually prostate artery embolization works really well, because the entire procedure entails me blocking off the blood flow to your prostate gland. So the chances of having significant bleeding from any intervention is significantly reduced. Now, folks often ask me, do I have to be off blood thinners in order to have a procedure with me? And the thing is, I'm going in with a very small IV in your artery here, a small 5 French sheath, for those who may be wondering. It's a very small little catheter there. And so most of the time, I very rarely stop blood thinners, because after we take this out, we just hold pressure. If you're on a blood thinner, I might have to put that little Band-Aid device for, instead of having it on for maybe just 20 minutes, maybe I need to keep it on for about an hour just to make sure that the blood vessel seals off well. But since it's a pretty quick procedure, I'm going into a tiny, tiny vessel that's literally about maybe 3 millimeters plus or minus in size. So if you have cardiac issues, and I have a lot of gentlemen, they may have underlying cardiac issues. They may have underlying reasons why they have to be on blood thinners. I don't even need you to stop this.
Okay, great. And then is there a risk of while you're going through the vessels, having some sort of injury internally in the body, in the blood vessels, where someone can start bleeding internally? Patients are wondering sometimes as this catheter goes in, what if you perforate through something? Is that even something that is possible?
It's always possible to injure a blood vessel when you're going through the blood vessel. Now, there are definitely steps that I take in order to mitigate that. So what do? I have special wires that I use that are not as traumatic. They're less likely to cause damage. I don't know if this is too much in the weeds, too technical for your audience, but instead of having a wire that has an angle that can easily puncture your blood vessel, I have special wires that have almost a J-shaped curve. So it's just literally, there's very few things for it to catch on. So especially when I make that trip all the way from your wrist and I'm going down around into your aorta, it should not be pushing off any plaque. Hopefully, it should not be scraping off any plaque. It should not be causing any dissections or any damage to your blood vessel wall. Now, let's just say worst case scenario, if I were to see that, I can always, try to, I'll give you an example. So there was a patient, we were in the pelvis. I was, in one of the blood vessels arising off next to the prostate. And we did see a little bit of what we call extravasation. It's just a technical term meaning that there's a little bit of blood that was not going where it should be. It was kind of going into the tissues around it. That's not a huge problem in that case because I was able to, in that particular case, I can hold up a little balloon to kind of prevent the seal off the vessel. So it's a thing that'll heal off all the time. I mean, we see it all the time that it happens. Not so much in the pelvis and the prostate. I do a lot of work in the legs, doing peripheral arterial work. I do see it there, but those vessels frequently heal up, and we'll know pretty quickly if you're having a problem. I'll see it when I'm monitoring your vital signs. If you're having a significant enough bleed, I'll notice maybe your blood pressure goes down. Maybe there's some changes in your vital signs, which if I'm not seeing that, you're usually doing well. So I've never had a patient who has complained, knock on wood, that of having any significant issue that causes any problems, especially after a prostate embolization.
Yeah, and I should point out too to everyone that the vascular interventional radiologists are the people we call when we have bleeding that we can't perhaps address through open surgery. We've done that for kidneys and bladder bleeding. Sometimes patients who had for prostate cancer, their bladder can start bleeding, and we have to call radiologists sometimes to help us out. For I guess a couple more questions as far as preparation, and then you mentioned a little bit about the postoperative. Patients could experience a little bit of pain and discomfort. How much pain and discomfort should they expect? What kind of medications do they need to take afterwards? And what is the preparation process for getting PAE done?
Sure. So the preparation process. So let's say we have identified you as a prostate artery embolization candidate. Or if maybe you're listening to this, you don't even have a urologist who screened you and you're just like, I have these symptoms and I want to get this done. So what's the next step? The next step is I would obviously see you in clinic. I'll probably evaluate some of your imaging to make sure you definitely have an enlarged prostate, look at your symptoms, make sure that it's your prostate that's causing your issue, that there's no underlying urinary or bladder issues that's causing it. But once we identify you as an actual candidate and we find out that, your insurance has been approved and you're now all set up and we tell you, you know what, you're going to come in on this particular day. Really, the only thing you got to do to prep the procedure is just, if you want sedation, make sure you don't eat anything after midnight. As I said, there's some patients who don't even want sedation. They just come in regardless. So you come into the procedure. It'll be a fairly routine procedure. Hopefully it takes about an hour or so. Then you stay after the procedure, maybe an hour or so. And then after the procedure, what will you expect? So I would say the majority of patients, a decent number of patients, will experience a little bit of some burning. Sometimes maybe a little bit of burning, sometimes with urination. It might feel like maybe a UTI, but we give you some medication for that. We have a few medications for bladder spasms if you're experiencing that. But the number one medication I always give, and I don't give it to some patients who might be potentially, if they're diabetics, is I give a medication I give is a steroid dose stack. Now, the reason I give a steroid is just to overall globally decrease the inflammation of your prostate in that first 24 or 48-hour period, because that's really what causes the most initial irritation, discomfort. And so when I give you a steroid dose back, that helps out. I also like to put you on anti-inflammatory medications. So you could take, sometimes I give patients like ibuprofen 800, which is really the equivalent of like 4 Advils. Most patients don't even need the narcotic medication. Every now and then I'll have a patient will say, I try and get a narcotic medication like an oxycodone, hydrocodone. Most patients, 99% of them don't need it, but if you really want it, maybe I give it to you for the first day or two just to get you through the night if it's really bothering you. But I would say that's the majority of drugs. I also give an antibiotic as well, because I want to make sure there's minimize the chance of having any infection. But really, the vast majority of patients do well with these, and hopefully you'll start to see some results within a couple of weeks at least.
No, I really appreciate your time, Dr. Rao, and I really appreciate you bringing your services here to San Antonio and this whole South Texas, Central Texas area. Your PAE has definitely come a long way from something that urologists have kind of just heard about to where we now have really gotten behind it, with the guidelines for the American Urology Association changing. And I'm sure we'll have some more talks about this in the future. But again, really thank you for your time.
Thanks for having me. It's great to see this procedure, which initially was very much kind of on the outlying edge of our IR space, being really accepted by the mainstream. It's great to see docs like yourself thinking outside of just your field and saying, what can I offer to a patient? Even if you're not providing the service, what can I provide to the patient to give them the access to the most newest current medical technologies out there?
Yeah, I appreciate it. Whatever we can do that's best for the patient, I really believe that is at the end of the day, well, you want to make sure everyone's happy, patients, and that means less issues for them, less headaches for us as their providers, just good outcomes all around. Well, thanks again.
Thank you.